the type of insulin and when to expect a hypoglycemic reaction. So dietary measures are very important to manage. Their physical activity is also important, and trying to come up with an exercise plan for the client. And look at their hypertension, have them usually control that with an ACE inhibitor or an ARB, can reduce the risk of diabetic nephropathy. And the statins to control their cholesterol, so including that as well. This slide shows you the actions of insulin. And the table, your table sometimes differs in terms of the actions of the different insulins and the rapid acting in terms of the onset, peak, duration. Sometimes it will differ by an hour or so, and or minutes. And so you want to be sure to use your ATI scales. And so for the rapid acting, according to ATI, the onset is 15 to 30 minutes. The peak is 0.5 to 2.5 hours, and the duration is 3 to 6 hours. Like you said, this particular slide shows 3 to 4 hours. The short-acting regular insulin, the onset is 0.5 to 1 hour. The peak is 1 to 5 hours, and the duration is 6 to 10 hours. And the intermediate acting, or the NPH insulin, which is the cloudy insulin, the onset is 1 to 2 hours. The peak is 6 to 14 hours. The duration is 16 to 24 hours. And the long-acting insulin, glargine insulin, the onset is 70 minutes. There is not a peak, and the duration is 24 hours, as you can see. So this slide was as close to the ATI as I could get, and so you want to be sure to use that as your rule of thumb. And sometimes if you, in looking at your textbook, it might differ for a half hour or so when you're looking at the comparison. It's very important, and that is shown for you in your textbook on the types of insulin. It's very important to know the peak because, for instance, knowing when to expect hypoglycemic reactions is very important when you're looking at working with a client who is a diabetic. And the signs of hypoglycemia, which is a blood glucose less than 70 milligrams, is a hypoglycemic reaction. Basically, they can have, as a result of the sympathetic nervous system effects, tachycardia, palpitations, diaphoresis, shakiness. It's abrupt. And gradually, the parasympathetic manifestations occur: headache, tremors, weakness, lethargy, and disorientation. As we do in the hospital, we give them 15 grams of carbohydrate. Usually we do grapefruit juice. We do glucose tablets, and we also do the gel there. And if the person is not fully conscious, you don't want to risk aspiration, so you give them IV glucose or subcutaneous or IM glucagon. So you watch the patient, depending on their peak, for the time when the hypoglycemic reaction will occur. And frequently this is an important aspect of care that NCLEX will ask about quite a bit. And the other thing you want to notice in terms of the long-acting is that the client you can see that there's no peak, and it's a basal cell. It continues. It's like your pancreas. We're trying to simulate pancreatic action as closely as possible, and so we've got a client just putting a little bit of insulin out over the 24-hour period. You also want to, of course, emphasize with the type 2 diabetic the prevention of complications and tight control of diet and physical activity, along with any medications they might be taking. Also, preventative types of things that you want to do to prevent the importance of foot care, not only for the type 2 but the type 1 diabetic. And we don't do the foot care, I don't think, enough. We don't teach the person to inspect their feet daily, wash them with soap and warm water, pat them dry, especially between the toes. You learned an assessment to separate the toes and look at the toes, and you want to do that. Powder with cornstarch is really good for sweaty feet. Not using open-toed sandals. Don't use the kind of caustic ointments and so forth that remove calluses and corns. Consult a podiatrist. Cut the nails straight across after a shower or bath, and file the corners. Avoid open-toed heel shoes, like I said. Good shoes. Don't go barefoot on the beach. You wear cotton or wool socks that have been mended. Certainly don't have any holes in them. If they've been mended and they have like a bunch that might put pressure on the foot, you don't want to use them. You want to be careful not to use hot water bottles or heating pads to warm the feet, especially if they have neuropathy. And avoid sitting, standing, or crossing the legs. And of course, the benefits is to prevent complications. As it's the hemoglobin A1C below 7% is good for most patients. The go below 8% is appropriate if they've got severe hypoglycemia and any kind of microvascular, macrovascular complications. Synthesis, you can read in detail about that. The care in this particular class, the care of the patient and the types of insulin, I'm going to spend more time on that. And we are very fortunate that at this particular time we have new concentrated insulins, and we used to have insulin, beef and pork insulin in the very beginnings, and now we have modified insulin as a result of DNA technology, which is very fortunate. And we'll go through the different types of insulin. The rapid acting insulin that you do have there, that's an example is insulin aspart. And then you have your short acting insulin, which is your regular insulin. We use that for IV purposes. And intermediate insulin, MPH insulin, that's is given sometimes in combination with the regular insulin, like 70/30, and we can give it now not just in a syringe, but we can also, and drawing it up, but we do insulin pens, and that's really helpful for a lot of patients who have difficulty with their sight. And then you have long-acting insulin, which is gives you a basal amount over a 24-hour period, and you have your pre-mixed insulins, mixture, like I mentioned, intermediate short-acting and intermediate and rapid-acting. I want to take a little bit more time because some of the slides before this on the other types of insulins that we just went through, we've had that in your basic, your Pharmacology 1 course. And so I want to take a little bit more time in the Humulin 500. And Humulin 500 is one of the first concentrated insulins. It's been available since the 1950s, but now we're putting it in pens. And obesity has led to this insulin resistance. So this U500 is 5 times more concentrated than the U100. And so less is needed per injection, so you're not giving huge amounts subcutaneously. So 1 milliliter contains about 500 units of insulin. And so we, usual dose, for example, for when we use the U100, required like for 100 units, 1 milliliter of dose. Whereas the same dosage with the U500 is requires like a 0.2 milliliters, so a lot less insulin. It's clear, it has a 30-minute onset. It stays at peak levels for about 7 hours, and it's available to the body for up to 24 hours. So the timing allows the U500 to be used alone to act as a basal or a bolus insulin. It was difficult to use prior to the pens because the client had to make a lot of conversions and so forth. And now that we have the pens, it is a lot easier. It's indicated for adults and children who need more than 200 units of insulin a day. But unfortunately, there's very few studies about the U500 with the children. It is, in terms of pregnancy, a category B and approved for use during breastfeeding. When you open a vial, it can be used for 40 days and the pen for 28 days before it must be discarded. And the unopened pens can be refrigerated, but you've got to be, you want to be careful not to give cold insulin. But the expiration date, and watching that, and should be discarded afterwards. The U500 isn't meant to use intravenously or as in an insulin pump. You'd use the short acting for that, and it shouldn't be mixed with other insulins. We don't mix the long acting as well. The main thing about NPH insulin is you want to be sure to, you don't want to shake it, you want to roll it before you inject it to disperse the particles throughout the insulin, and take the time to do that because it's a cloudy suspension. And then when you're giving the injections of insulin, you want to, the abdomen is the best place to give it, and you want to be sure to rotate the insulin areas, and so you want to give it 1 inch apart and 2 inches from the umbilicus, of course. And the long acting is basal. A lot of times people, it's not used like the short acting with meals and to cover your carbohydrates. It's to give a basal small amount of insulin throughout the day and to stimulate as much as possible the pancreas. And as you can see, the long-acting insulin, we do not give that IV. We don't mix it with other insulins. It's usually only given once a day. So looking at other long-acting insulins, the newer ones that we do have, you've got the degludec, the U200, and this is a long-acting concentrated basal insulin that contains 200 units of insulin per milliliter. It comes in the standard 100 milliliters per milliliter concentration. as well, so you don't want to confuse the two. The 200 pharmacokinetics includes the longest half-life of any of the basal insulins and can last 42 hours. It achieves a steady state in a couple of days, 3 to 4 days, and that's also the recommended interval between dosage adjustments. You should wait that long. It has a slow, prolonged effect, and so it is quite forgiving in terms of its administration. Patients shouldn't administer doses fewer than 8 hours apart. It's done daily by subcutaneous injection. It comes in an insulin pen. Adults who change from one basal insulin to this insulin should use the same dosage. Children should usually reduce the dosage by about 80%. It isn't recommended for pediatric patients, though, who use less than 5 units per day. And it can't be used in an insulin pump or mixed with other insulins. And then another new one, the Lispro U200 is a non-basal, rapid-acting concentrated insulin. It's given then with, because it's rapid-acting, it's given to cover the carbohydrates. It's given with meals, and for glucose corrections. Glucose corrections is that you cover the carbohydrates, but if the glucose is really high, the blood sugar is really high, the doctor would have given a correction as well, and so you add some insulin to the meal dose. And basically, it's indicated for children and adults, but it hasn't been studied in children less than 3 years old. It shouldn't be administered intravenously, used in an insulin pump, or mixed with other insulins. This one. It can be used in pregnancy, and it's compatible with breastfeeding. Can kept at room temperature for 28 days, and the unopened pens can be refrigerated just like the vials, but you want to watch the expiration date. It talks about the insulin appearance, that you want to roll it between your hands, not shake it. That increases the amount of air bubbles, and that's harder to draw up, because air bubbles will then give you less insulin in the syringe and will take up space that the insulin should be in when you're drawing up the insulin. When you're mixing it, that's pretty important. When you're mixing it, you want to not put the main goal is you don't want to put the intermediate acting into the regular acting insulin, because that will change the duration of action and the peak. And so the short acting insulin is drawn first, and that's important to know. And we are seeing more and more of the children with the insulin pumps and the portable insulin pumps in the schools. And so school nurses have to know about doing the pumps. We're getting more persons in the hospital who have pumps. And so it's very important that we also know about how to manage those pumps. And I've not seen very many of the implantable insulin pumps. Basically, the school nurse then helps them take care of their diet, their insulin, changing the pump, changing the dressing, usually about every 7 days, and helps them with that. The pumps are very effective in that they simulate the normal pancreatic release of insulin. So we used to store all of the insulin in the refrigerator, but we don't, just the unopened vials, but you want to keep track of the expiration date. So the use of insulin is for certainly diabetic ketoacidosis, gestational diabetes, and type 1 diabetes, some type 2 persons as well. You also have to watch the potassium, can promote the uptake, hyperkalemia. And the growth hormone. Hyperglycemia, where I talked about the signs and symptoms of the hyperglycemic reaction, can occur from the overdose of insulin, too little food, if the patient is ill, vomiting or diarrhea, alcohol intake, if they've had too strenuous an exercise and they haven't covered, they've had a dose and then exercised too much, and so that the unconscious person, IV glucose or the parenteral glucagon, subcutaneously or IM. We want to watch for lipohypertrophy, assessing the arms. We used to do the arms and of course the legs, and certainly when people like to rotate, especially older persons, they'll ask you to put it in the arms and legs, but you try to encourage them that the abdomen is the best place to put it. Allergic reactions, I've not seen any in terms of insulin, but you do want to watch out for that. Watch the person for their potassium levels, and that influence the uptake of insulin into the cells. And so that lipohypertrophy, you're rotating the syringes, that's very important. And then we're going to talk about the hypoglycemic agents a little bit more in detail. So the hypoglycemic agents, you've got the older agents, metformin. That's the one thing that we want to be aware of in terms of metformin is that when the person, that's usually held for 48 hours if you're giving someone contrast dye, and that they're getting injectable contrast dye with their test. Metformin is a biguanide, and it's a biguanide reduces the production of glucose within the liver by suppressing gluconeogenesis and the release of the breakdown of sugars through the liver, and then it increases the muscle's glucose uptake and use, and it's one of the first categories that we had. It's got quite a few side effects, GI effects, anorexia, nausea, diarrhea. Frequently results in weight loss, and it can cause vitamin B12 and folic acid deficiency, so supplements may be provided, but the main thing is causes lactic acidosis, hyperventilation, sluggishness, somnolence, and has a 50% mortality rate. So if it gets very severe, you might need hemodialysis. And then the sulfonylureas, an example of a sulfonylurea is glipizide. You want to, they help the insulin release from the pancreas. It's another one of the older ones. Glipizide, it's you want to watch for hypoglycemic reactions, just like with insulin. And not that the others don't, but this particular category does. You see quite a bit of hypoglycemic reactions with these folks. And so instructing the person to take a snack with them at all times, and how to treat the hypoglycemic reaction would be important. Wearing a medical alert bracelet would also be important. The glitazones, that an example of that is pioglitazone, and essentially the glutazones increase the cellular response to insulin by decreasing insulin resistance. It increases the uptake of the sugar and decreases glucose production. Pioglitazone, you have to watch out for fluid retention. So watch the person, if they have a cardiac history, used with caution. They could have congestive heart failure. They also elevate the LDL cholesterol, and so monitor their cholesterol levels. It can cause hepatotoxicity, so monitoring their liver function tests and taking a baseline test, watching for jaundice, darken of the urine. And then you have the glynides. An example of the glynides is repaglinide, and basically these particular ones, Thea, they also help the insulin release from the pancreas like the sulfonylureas, and so act pretty similarly. And you want to watch them for hypoglycemic reactions as well. So this goes into, like I said, the lactic acidosis. The sulfonylureas. The glynides. The glitazones. And the alpha glucosidase inhibitors, those like acarbose is an example of those. They slow carbohydrate absorption and digestion down. Basically, some of the side effects of those are GI effects, distension and cramping, diarrhea, and so watching the impact and discontinue the medication if it becomes especially uncomfortable to the person. They can have cramping. And anemia due to decrease of iron absorption, so watching their iron levels, and it can cause hepatotoxicity. So watching the liver function tests and watching for signs of jaundice. The DPP-4 inhibitors are relatively new. They extend the incretin hormone action time to help facilitate insulin secretion. And sitagliptin is an example. They're approved for the treatment of type 2 diabetes in terms of, as with all the type 2, you want to emphasize diet and exercise. And frequently they're used as a second-line medication in addition to one of the other categories. And they can be used as monotherapy, though, and they are able to reduce the hemoglobin A1C with no problems in weight or changes in lipids. Some of the side effects is they don't cause weight gain. That's one of the benefits. And they're taken once daily with or without a meal. But if used in combination with another one, you would want to do it with a meal. And the dosage is lower for a patient with renal insufficiency. It's a pregnancy category B, but it should be used in caution with persons who are breastfed. And the most common adverse effects: nausea, vomiting, respiratory infection, allergic reaction, and pancreatitis has also been reported. there's a warning with some of the ones in this particular category, sagagliptin and alogliptin, that increases the risk of heart failure in persons, especially with a pre-existing heart or kidney disorder. And they've also been known to cause very severe, in a 2015 study, very severe and disabling joint pain. And so you want to ask the persons and keep monitoring them for any reports of joint pain from the first day, and sometimes it can be years after starting the medication. And usually when they discontinue it, at least at this point, the symptoms have disappeared after they've stopped the medications. Another category that's relatively new is the sodium glucose cotransporter 2 inhibitors. And these work in the proximal tubule of the kidney to mediate reabsorption of glucose and increase glucose secretion in the urinary tract. And so the result, it lowers blood glucose. It's used as monotherapy or in addition to another diabetes medication. It reduces the hemoglobin H1C. Other benefits include weight loss, reduced blood pressure. It reduces the obesity, the waist circumference, uric acid, and some of the ones, dapagliflozin, reduces the progression of albuminuria with the person with renal failure. And we also want to watch the cholesterol levels. Usually this category is amended once a day, and it's indicated in addition to diet and exercise for type 2, of course. And you want to watch the glomerular filtration rate with the diabetes. Some of the adverse effects is urinary frequency, increased risk of urinary tract infections, genital tract infections, especially in women, postural hypertension, ketoacidosis, injury to the kidneys, acidosis, and fractures. And so that it is new, but it does have a bit of side effects to it. Then you've got the GLP-1 receptor agonists, or the incretin mimetics. It is an incretin hormone produced by the small intestine when the oral glucose is ingested, and it promotes insulin secretion by the pancreas and suppresses glucagon secretion in the liver. It delays gastric emptying, so it slows glucose absorption and increases the feeling of being full, so suppresses the appetite. It can facilitate weight loss, and exenatide is indicated as an adjunct to diet and exercise with persons with diabetes. And this particular category is effective as the others that I mentioned, the newer ones, lowering hemoglobin A1C and causing weight loss, blood pressure reduction, improved glucose levels, better beta cell function, and cardiovascular benefits for the person. In one study of persons that had high risk for cardiovascular disease, when they took this particular category, they had reduced cardiovascular events. In these receptors, it doesn't cause hypoglycemia. However, if it's combined with one of the other agents, you want to watch for it. And it's indicated for type 1 diabetes, but it hasn't been studied in children. It's a category C in pregnancy, and use with breastfeeding is not recommended. Adverse effects, nausea, vomiting, diarrhea, and precautions include a pancreatitis and thyroid cell carcinoma that has appeared in persons who have taken this particular oral agent. And then the acute complications of diabetes, diabetes ketoacidosis, and you want to watch for the signs and symptoms of that. And the cardinal signs and symptoms is hypoglycemic crisis and a loss of fluid and electrolytes in both conditions. Ketoacidosis is the one that is differentiates diabetic ketoacidosis, but it's absent in hyperosmolar hyperglycemic state. So these slides talk about ketoacidosis. So mainly the issue with hyperglycemic hyperosmolar non-ketotic syndrome is because of the large amount of glucose excreted in the urine, they're also losing blood volume and becoming dehydrated. This shows you a side-by-side. The symptoms are similar except for the ketones. So you're mainly fluid replacement is very important with the hyperosmolar non-ketotic syndrome. Glucagon, one of the problems with glucagon is that we weren't getting enough for the clients in the schools, and glucagon increases the blood glucose levels by increasing the breakdown of glycogen into glucose and decreasing glycogen synthesis, thereby enhancing the synthesis of glucose. It's an emergency management of hypoglycemic reactions, such as an insulin overdose, and in clients who are unable to take the oral glucose. I'm going to go back to the questions so you have a little bit more time to look at those. And I would also look at your questions that are in your ATI book and go through those.